Bismillahirrahmanirrahim. The topic of our discussion today is acute cholecystitis. So, acute cholecystitis refers to acute inflammation of gallbladder. There are two types of cholecystitis. The first is calculous cholecystitis, which results due to obstruction of gallbladder by stones. Almost 90 to 95% of the cases of acute cholecystitis are calculous cholecystitis. Acalculous cholecystitis means gallbladder infection in the absence of stones. Almost 5 to 10% of all cholecystitis are of acalculous type. Most common infective organisms resulting in cholecystitis include E. coli, enterococci, and Clostridium bacteria. So coming on towards the pathogenesis of acute calculous cholecystitis, the main culprit in this case is presence of gallstones. So these gallstones present inside the gallbladder obstruct either at the neck of gallbladder or they obstruct the cystic duct. So this obstruction leads to increased retention of bile inside the gallbladder. Hence the gallbladder becomes distended. The distension of gallbladder results in the loss of peristaltic movements and hence loss of motility. So there is decreased drainage of bile which accumulates inside the gallbladder. Moreover, the increased pressure inside the gallbladder results in the compression of blood vessels, hence resulting in obstruction to the blood flow. This obstruction leads to ischemia, and hence there is an ischemic as well as a mechanical injury to the gallbladder mucosa. Moreover, the injured mucosa also releases a specific enzyme known as phospholipase. This phospholipase hydrolyzes lecithin, hence converting it into lysolecithin. This lysolecithin is extremely toxic to gallbladder mucosa, and it also results in the disruption of the glycoprotein mucus layers which surrounds the gallbladder mucosa. One thing to remember here is that mucosa means the inner epithelial layer, whereas the mucus means a specific glycoprotein secretion which covers the inner epithelium, protecting it against the toxic and detergent action of the bile. So lysolecithin dissolves the mucus as well as it is toxic to the mucosal membrane. So once the mucus layer is disrupted, the lysolecithin damages the mucosa or epithelial layer, hence resulting in the injury and ultimately inflammation. The injury to mucosa is occurring due to, first of all, the detergent action of bile, lysolecithin, and also prostaglandins. So this type of injury is known as chemical injury. So in acute calculous cholecystitis, there is mechanical, ischemic, and chemical injury to the gallbladder. Moreover, in the cases of gallbladder obstruction, there is also an increased risk of infection. Therefore, a superadded infection can also occur later on in acute calculous cholecystitis. The important point to remember here is that the infection does not develop at the beginning of the disease. In the later stage of the disease, bacterial growth can be sufficient enough to cause the infection. Coming on towards acalculous cholecystitis, there are certain predisposing factors such as infections, immunosuppression, certain cases of trauma and burns. Moreover, in diabetes as well, there is an increased chance of acalculous cholecystitis. So once the infection develops, there is inflammation and edema of the surrounding tissues. This edema compresses the blood vessels, hence compromising the blood flow. One thing to remember here is that the gallbladder is supplied by the cystic artery. Cystic artery is an end artery, and end artery means that it has no anastomosis. So once the blood supply gets blocked from the cystic artery, there is no alternative pathway to supply the blood. So this compromise in the blood flow results in the ischemic injury, causing gangrenous cell death, ultimately leading to acalculous cholecystitis. The most common organisms involved in acalculous cholecystitis include E. coli, Clostridium, and Enterococci. The gross appearance of an infected gallbladder reveals enlarged size and erythematous outlook. This erythematous outlook or redness is due to serosal hemorrhage. Over time, this serosal hemorrhage can become discolored, giving it a greenish to blackish kind of appearance. The serosa is also covered with the fibrinous exudate, which in more severe and advanced cases becomes purulent. The lumen of the infected gallbladder reveals stones and turbid, cloudy bile. This turbidity and cloudiness is due to presence of infections. Moreover, in very severe cases, there could be a purulent exudate which completely fills the gallbladder, and it is known as empyema. In the mild forms of acute cholecystitis, the bladder walls are thick, edematous, and hyperemic. Whereas in the severe infection, the walls are greenish to black in color, which is due to gangrene of the gallbladder wall. The histological picture reveals the presence of neutrophils, which indicate the acute inflammation. Moreover, certain necrotic tissues are also present in the histology, demonstrating gangrene. The patient commonly presents with the right hypochondrial or epigastric pain. The pain is often radiating to scapula, and the patient also complains of fever. The fever could be of low or moderate grade, and there is also nausea and vomiting. The patient suffers from complete loss of appetite. One particular sign on the examination is the positive Murphy sign. So the patient is advised to lie down flat on the couch, and the pressure is exerted right beneath the rib cage. As you can see here, the pressure is exerted on the right hypochondrium just beneath the rib cage, and the patient is asked to take a deep breath. Once the patient takes the deep breath, the gallbladder distends down, and once it makes contact with the pressed down abdominal wall, the patient experiences the pain. This is known as positive Murphy's sign, and it indicates inflamed gallbladder. The blood picture reveals leukocytosis and particularly increased quantity of neutrophils, which indicate acute inflammation. Moreover, LFTs are normally not elevated, but if the gallstone distends down and blocks the bile duct, there is an elevation of ALP and serum bilirubin levels. The ultrasound abdomen reveals inflamed gallbladder, and it is also helpful in determining gallstones and sludge present inside the gallbladder. The treatment of acute cholecystitis is with IV antibiotics and NSAIDs. Broad-spectrum antibiotics such as ceftriaxone is mostly used, and the patient is always treated as an emergency case in the inpatient. Once the infection settles down, the definite treatment is surgical removal of the gallbladder, also known as cholecystectomy. Cholecystitis can also result in certain complications such as empyema. Empyema refers to the gallbladder which is completely filled by the purulent exudate or pus. In certain untreated cases, the bacteria damage the mucosal membrane and progressing deep into the gallbladder wall, resulting in disruption of the gallbladder wall, also known as perforation. In case of perforation, bile is drained directly into peritoneum, which leads to acute peritonitis. Acute peritonitis is a surgical emergency. The infection from gallbladder can also spread into the blood, resulting in sepsis. Sepsis can progress into septic shock and can prove to be fatal if not taken seriously. Sometimes a fistula is formed between the gallbladder and the intestine, known as cholecystenteric fistula. In these cases, bile and certain other contents of the gallbladder, such as gallstones, can directly drain into the intestine. The gallstones in the intestine can cause intestinal obstruction, resulting in a condition known as gallstone ileus. Intermittent acute infection can also progress into chronic cholecystitis if left untreated. Chronic cholecystitis poses a major risk of porcelain gallbladder. Porcelain gallbladder means calcification of gallbladder wall. This calcification increases the risk of gallbladder carcinoma. So this concludes our discussion about acute cholecystitis. If you have any questions, do let us know in the comment section.